And to bring us back, I wanted to just do kind of a brief recap of what we've heard this morning. So over the course of this morning, we've heard several really poignant examples of how patient engagement has facilitated better care and better business for health systems. In our first session with Joy, we heard the vision for how UW Medicine is aligning our technical tools to better serve the needs of clinical and administrative teams, and the opportunities that will invite to advance patient engagement. Then we heard about advancements in the policy and technology environments that are making patient engagement such a critical area for how health systems operate. And we were reminded of how important it is to keep patients and their experiences at the center of our planning, strategy, and delivery. We then heard from two health systems who gave us some very great examples of effective but different approaches to managing digital health and patient engagement. And these speakers gave us lessons about the importance of investing in thoughtful innovation and showed us that innovation can look really different. Sometimes innovation is about using a new tool, but sometimes innovation is about taking a new approach to the tools that we already have in place. So throughout the morning, there have been several recurring themes here. So we've heard a lot about access and branding, patient care, care coordination, business operations, and innovation. And each of these themes are important by themselves, but they also, as we start to think about patient engagement as a continuum, they're very interconnected and can enhance one another. So as we head into the second part of our workshop, I really encourage us to think about the question of how do we grow and continuously mature our engagement with UW Medicine patients. So we showed this visual earlier this morning, and that sort of reflects our continuum of patient engagement. And I'd like to dig in a little more and share some of the examples of how UW Medicine is currently advancing these areas. When we look at the area of access, we think about the work that's been done to support e-care sign-up, direct scheduling, virtual care, and telehealth, offering patients novel ways to access the care that they need. When we look at the area of patient care, we think about the tools that we have developed to help capture patient voice and support population health management, and how the expansion of these tools can continue to improve the visit experience and make care more patient-centered. For care coordination, we think about the resources we have to provide patients with information and tools to manage their diagnosis and treatments, and the opportunities D1 and a single record will offer. And lastly, the work done to standardize best practices and make administrative processes more efficient will help UW Medicine patients have a more seamless experience in their care and follow-up. So this is not an exhaustive list, and this reflects work that many of you in the audience are leading, and I want to acknowledge those efforts. But I show these as an example of what we have done and where we can go. Each of these can be thought of as a touch point that can strengthen a patient's relationship with UW Medicine as a brand and increase their involvement in their care. So I want to share a brief case study before we go into our speakers. As we start to use some of these tools, I think it's pretty apparent to us that we have a lot to learn about what to expect and what makes patient engagement work. The example here and the more detailed case studies that you'll hear from Dr. Chang and Dr. Crane are meant to help us start to understand what can make patient engagement successful for UW Medicine, and where do we need to continue to iterate and learn from each other's experiences. The example shown here is for the Medicare Annual Wellness Visit Health Risk Assessment, or HRA questionnaire. The HRA questionnaire is a 45-question survey, and when done on paper in the waiting room, it takes patients an average of 20 minutes to complete. The questionnaire was built into eCare and piloted in 3 primary care clinics representing our UW-MC Montlake campus, the UW-MC Northwest campus, and then one of our neighborhood clinics. And I want to acknowledge the tremendous support that we had from the clinical teams supporting these pilots. When we started the pilots, we knew the average eCare sign-up rates in these clinics, which ranged from about 60 to 80%. But we didn't know anything else about their patterns of eCare use or what to expect if we were to send them a survey and ask them to complete it before their visit. Over the course of the pilot, 260 questionnaires were sent out to Medicare patients with active eCare accounts. And of those, close to 70% opened that eCare message, and close to 45% completed the survey before their visit. To build off some of the comments that I know Dan made earlier, thinking about how do we measure success in these types of scenarios, I look at this in a couple ways. I see 45% as an opportunity for us to build and grow and increase that. But I also look at that and see that almost 130 patients had a shorter waiting room experience, and that's pretty meaningful to them and to our system. Through the pilot, we also sought feedback from patients and providers about their experience with the eCare HRA, and their feedback was overwhelmingly positive. For patients, they appreciated the opportunity to take their time in completing the survey and use that process to identify their priority questions for the visit. Providers appreciated having the data available electronically and before the appointment for them to review, and allowed them to spend more time during the visit focusing on the care needs that mattered most to the patient. Again, reflecting on the issues of pilotitis, as we start to scale these tools across UW Medicine, we're met with a lot of complexity and a lot of challenges. And in the HRA experience and in the case studies you're about to hear, there are several common themes that continue to persist and guide our understanding of how to support patient engagement work. First, getting workflow right is critical, but it's also an iterative process. Second, technology and data need to align and add value to patient care. We must ensure that the data that we're providing is sent to the right people at the right time and allow them to actually act on that data. And we're always trying to balance standardization and customization, as well as automation versus in-person use. There's a lot of issues that we're trying to find the right balance of. Getting feedback from users throughout the process of planning, designing, and implementing these tools will be critical to our success. And then knowing what we mean by success and iteratively evaluating that will really help us learn, not only in the pilots that we're working on, but across the system at large. So I want to introduce our two speakers. I'll say that when we were thinking about potential speakers, there were a lot of opportunities across UW Medicine of great examples of patient engagement. But we selected these two speakers because of their experiences and how they highlight the successful use of data to drive care, as well as great examples of how to continuously learn and improve the process of engaging patients. Dr. Denise Chang is a clinical associate professor in the Department of Psychiatry and Behavioral Sciences and medical director for the Behavioral Health Integration Program. Dr. Chang will share her experiences implementing the PHQ-9 for depression screening and management through our patient portal. Following, Dr. Heidi Crane, Medical Director of HMC's Madison HIV Metabolic Clinic and Associate Director of CFAR Clinical Epidemiology and Health Services Research, will share her experience implementing PROS through an external platform to support the evaluation of complex care needs. So I welcome Dr. Chang to start us off.
Thanks for having me, and thanks for inviting me, Elizabeth and Danielle. This has been a great morning to hear from all the other folks about the innovations that are going on and sharing a lot of these ideas. So it's been wonderful to hear a lot about these. And I'm here to kind of bring some of the clinical experience that we've had in this case study of bringing the PHQ to UW Medicine, and in particular using depression as an example of how we might use PROS work and building it into our electronic health record. So just as an introduction, again, I'm Denise Chang. I'm a psychiatrist here at the UW. I work as a consulting psychiatrist in the primary care clinics, and I'm also the medical director of our Behavioral Health Integration Program, which is our integrated care, collaborative care program, which you'll hear a little bit about in this presentation. So as just an overview around PROS expansion project in general and what we were kind of working under this purview, it was between February and September of last year, and the goal was really to develop tools for the core PRO domains, and depression was highlighted as one of the priority areas we wanted to look at, partly because of the importance of depression, which I'll talk about, and as well as the fact that it touches so many other different areas of medicine. Another highlight was really trying to align the standards and recommendations so that we can use that information for future PRO builds. So really my goals for this session are to really give you some concrete examples of our case use, how we use PROS to hopefully engage patients through technology, how it can be used to support clinical care, and discuss the challenges, lessons learned, and some of the complexity that's involved from going and inputting more PROS. So case study for depression. So why depression? Why is it a priority? And so, this is speaking to, everyone in the room, not just clinicians here, is, we're going to talk a little bit of why depression, how we measure depression symptoms, what we're doing in UW Medicine around depression initiatives, and then why we're using the patient portal to capture these PROS, and what challenges we have seen by doing this electronically. So just launching right into depression, why it's important. So this is data that it's a few years old now, but we did a process of empanelment, so we kind of identified all the patients that we have here at UW Medicine, and that was roughly about 240,000 back in 2017 that are getting primary care in our UW system. And when we look at that and how many of the patients have depression, you can see this kind of sliced pie here that some of them, with the really severe symptoms are kind of accessing our more higher intensive services like inpatient services or residential services. Some of them are getting outpatient care at our UW clinics, our specialty clinics for psychiatry. Some of those patients are receiving care in the community, private practice, other places in the area. And then there's also a layer of BHIP. So we have these behavioral health integrated programs where we're doing collaborative kind of co-management and collaborative care with a social worker in the primary care setting where we're helping care for patients in and having a behavioral health team set right in the primary care clinics. And that's available in many of our primary care clinics. But as you can see, the grand majority of patients are primarily being managed just by a PCP alone, and that's about 85%, which comes out to be nearly 35,000 of our patients are being managed by a primary care physician. So we really want to look at how we can do certain initiatives in the primary care space because that's where most patients are receiving their behavioral health care. And so that brings us to the PHQ-9. So this is the Patient Health Questionnaire, and it's 9 for 9 items. It's a subset of a larger questionnaire, but this is really focused on depression symptoms. This is kind of our validated tool that we use to not only measure depression severity, but it also helps with screening, assessment, tracking patients of how they're doing over time. It's a validated tool with good sensitivity and specificity, and it really helps guide diagnosis. While it's not technically a diagnostic tool, all the 9 questions line up with the DSM criteria for depression diagnosis. So there's 9 items here, including the 9th item I'll point out now, since it's something we'll reference later, is a question about suicidal thoughts for patients, since that's obviously a key important feature that we want to know about if someone's having those symptoms. So that's one of the questions. There is also another version called the PHQ-2, which is an ultra-brief screening tool, which is really literally just the first 2 questions of this 9-item questionnaire. So oftentimes in settings like primary care, we use the PHQ-2 for a screening tool, and then if that's positive, we then ask them to cascade and do the full PHQ-9. So that's a little background about the PHQ-9. In current status, we're doing paper forms of this. So that's, as like all questionnaires really have been, always originated on paper forms, and that's what our current practice really is at the UW Medicine, is using a paper PHQ-9. So we'll talk a little bit about how we're trying to transform that. But taking that PHQ-9 as the tool that we use, and you can quite equate it as an analogy of, this is our version in behavioral health as our blood pressure. So we don't have an objective tool to measure someone's symptoms. This is the closest that we have. So we really rely on this to be able to track over time how someone's doing. And this leads us to be able to do measurement-based care in behavioral health. So really it guides us to take patient-generated health information, take a systematic approach to looking at that and measurement of patient symptoms, and then help inform us as clinicians to make treatment decisions. So if we see someone's PHQ-9 scores going up, they're getting worse, their treatment maybe isn't effective or working, that we have our ability to track that and look at that, and the clinicians say, seems like something's not working, let's talk about your treatment plan, let's review that. So it really informs treatment decisions. It also can help on a population level identify patients that are not improving, and we can do targeted approaches. And this is how we really do our kind of case reviews in our integrated care model in the clinics. We take a population of patients that we're following on a registry, and we target our approaches to those patients that aren't improving, that their scores are still elevated. So we can do a targeted approach, or what we like to call treatment to target. So we're continuing to make sure we don't fall into treatment inertia, where someone is getting on an antidepressant, they're on it for 2 years, but their scores are really high, but they're kind of flying under the radar. This really kind of brings to the forefront, hey, this patient's scores are still really high, and we really need to address maybe something as a change, so treatment to target. So taking that idea of measurement-based care and then really kind of taking it to a patient-level example. So where, as a patient, would you see a PHQ-9? So you can see it in the screening process, and diagnosis and treatment, and also monitoring. So this is just demonstrating where a PHQ-9 is used. So typically, for depression screening, someone would get a PHQ-2, and if that was positive, as I mentioned, they'll get the full PHQ-9. That PHQ-9 could also be helpful in creating assessing for a diagnosis. It measures the severity of symptoms and guides diagnosis and treatment, like we were talking about. Also does that treatment to target monitoring of patients over time and trending that data. And as a note, when we have patients with depression, after they do enter remission, we then screen them annually with a PHQ-9. We don't have them go back to the population level screening of a PHQ-2. So that's a patient example. Now switching over to kind of the population health initiatives that we're doing here at UW. This is the population health approach, and this is where you would see PHQ-9s used on a system level. So in our system, I'll just run through these quickly. Each of these we could talk about for hours, but these are the population approaches that we're doing, and I'm a part of. It's the other hat I wear. These are the things that we're trying to do to improve depression care here at the UW. One of them is the depression clinical pathway, which is really a clinician decision support tool built into our EMR. It's really a set of guidelines to help a physician, use the PHQ-9 to help guide treatment, and I'll show you an example of that in a second. The other program that we're doing right now that I'm involved in is the depression population approach to health with a PATH program, and that's a centralized approach. So you have a psychiatrist, a social worker, a centralized team monitoring and managing outlier patients with elevated depression, persistent, elevated scores, and doing that for a focused population. Right now we're focusing on our ACN patients, but we hope to expand that. And our expansion plan is really doing this, the depression panel management. So you have a PATH program, which is centralized, and panel management really is utilizing the local teams built within a primary care setting to bring a systematic approach to a provider's panel of depressed patients. So having a routine, systematic way to kind of look at a provider's registry of patients, which ones are depressed, using the PHQ-9 score to help do that treatment to target and measurement-based care that we're talking about. So I just wanted to highlight these are all the initiatives where we use PHQ-9s in all of these initiatives and at a population level, and the fact that also, with our quality and performance metrics are tied to those PHQ-9s as well. So that's also another incentive for us to really want to get this right, make sure we're capturing PHQ-9s as well. So staying to the idea of how much we rely on PHQ-9, both on a patient level as well as a population level. And so this is just a visual of kind of the algorithm that exists with the depression clinical pathway. That's our clinical decision supports tool in the EMR, just to give you a highlight of where all the areas where we use PHQ-9, we use it to help screen people in, and if they get positive and they have a diagnosis of depression, they get put on this pathway. And then also the severity of symptoms helps define kind of what treatment step is going to be presented to you as a provider. And this is the rest of the algorithm. And then, as management steps, we're asking patients to get a regular PHQ-9s at a certain interval so that they can be monitored and tracked. And then again, once they hit remission, they go off the pathway, but then they're still going back to an annual PHQ-9 screening or monitoring, So that's one kind of visual. And then this is also just the kind of way we trend the PHQ-9 in our EPIC, in our EHR. So this is just another visual showing what trended data looks like and allows for that measurement-based care that we were talking about. So stepping back, we have the paper version. That's what we currently use and what our standard is. And we want to move to a computer version, obviously the online, using patient portal, allowing patients to enter this self-reported symptom directly into the patient portal so that it can be received and reviewed by their provider. And the reason why really to do this is all the things that we've been talking about today: patient engagement, supporting clinical care, improving the data capture, improving clinical efficiencies. Now, this seems like it should be an easy process. Just put the paper form and digitize it and make it available online. But we're here to talk about some of the things that we came across and that we learned around the design of this. So the design really, when we went to it, we had to think about what are the key functionalities that we have to have available in electronic PHQ. And one of them is having multiple workflows. So one of the reasons for this tool is really to do screening on a population level. So really we wanted to be able to do something what we're calling auto-attach. So really identifying patients that have an annual wellness visit or a routine that are due for their yearly screen, auto-attaching this to be sent out automatically to patients 7 days ahead of their scheduled appointment. So the system will kind of cull the system, know that, okay, this is an annual wellness visit, use the health maintenance reminder, which we'll talk about in a second, to say, oh, this patient is due or overdue for their PHQ-9 or PHQ-2, and then it will automatically attach it to their appointment and just send it out automatically to the patient prior to their scheduled appointment. So there was an automated workflow, and that's really targeted towards screening patients. And then we also built a manual workflow. So this makes more sense to some of us that say, oh, I want to make sure that patient's going to be leaving to California for 2 weeks, and I want to follow up on their depression. I want to just be able to manually send it out so I can follow up with them. And then it could be an individual outreach, and And some of those initiatives that I was talking about, like panel management, we might do batch outreaches. So we may say, these 10 people are kind of fallen out of care. Their last PHQ-9s were elevated. I don't know what happened to them. Let's send them a batch, send all these 20 people, an e-care PHQ-9 to see, how they're doing. So there's kind of uses for a manual send out and in addition to an automated send out. So we built 2 different workflows around that. We also built in branch logic, so obviously when a patient scores positively for PHQ-9, we want the system to automatically branch to a full PHQ-9. We also wanted to be clear about how the data is going to flow. So, when the patient submits it, where does it go in the system? Who looks at it? How is it reviewed? How is it filed? How is it stored? We had to make all those considerations. And then, of course, our biggest concern is looking at that question number 9 that I pointed out, that suicidal ideation question, the question about suicidal thoughts. We want to make sure that that's flagged appropriately so that providers can see that and make sure that they respond to that appropriately. So those were just some of our basic design functionalities that we looked into and had on the top of our head. And this is kind of the timeline that we did. So we took our tool that we wanted to build, we did a design and build for those workflows. Then we did a pilot kind of in the fall. And then since the fall, we've been doing ongoing kind of process improvement, kind of looking at different things. And we've really focused on 2 clinics, one that's really focused on doing that automated process and one clinic that's really focused on doing the manual so that we can learn on how, there's still a lot of learnings, which we'll talk about in a minute, but then how do we eventually scale this is what we've been talking about here today. So I'll just give you a brief overview of the data. So we won't get too into the weeds with the exact data, but you can see there's the manual send out as well as the auto attached send out. Now the key take homes here are obviously the auto is going to be a lot more in terms of just overall overall number. They're being automatically identified by the system and sent out automatically. So on a large scale, we've sent out nearly 2,000, over 2,000. The manual send-outs are all dependent on the person who decides they want to send it out, right? I want to follow up with this person or these 5 people I want to kind of outreach to. So those were much smaller in number, but the interesting thing is the manual send-outs seem to have a higher submission rate. So maybe it's the patient got informed by the provider, I'm going to send this to you via eCare, so I want you to respond back. So we had closer to 40% response rate as opposed to the auto. If you're just getting it automatically attached to your appointment coming up, the response rate was closer to 14, I think. So overall, larger number, lowest response rate, but manual, lower number, larger response rate. That's what we've learned so far. And then the key thing that everyone wanted to know is what about those high-risk responses? So the high-risk response, anything positive, we were marking with a red flag for patients or providers to note. And overall, out of all the over 5,000 that we've sent out so far, there's only been 30 that have marked anything but a 0. So if you do that percentage-wise, that's 0.6% of the responses have come back with a high-risk response. So that gives us really good data because we didn't really have that data before, because that was the big concern before we released this electronically was, what about those high-risk responses? And we'll talk about that in a minute. But the data helps kind of identify what the likelihood of that event would be. So getting right into that, what are the challenges and lessons that we've learned? One thing is, as I think Elizabeth mentioned, getting the workflow right is critical. So we really want to know how to standardize workflows just in that kind of data flow. Once a patient submits it, who's receiving it, who's submitting it, or who's filing it, how is it getting from who's filing to the provider if necessary, because the person receiving it may be an MA, but if there's a high-risk response, how does it get from the MA to the provider? How are those high-risk responses handled is the next point. But the workflow is really key in kind of like who's reviewing the information. The next is the big elephant in the room is how do we review and respond to those high-risk responses? That was one of the biggest concerns moving to from the paper to the electronic version. So as you can imagine, a lot of providers, paper form, they get the paper form and they have the patient right there in front of them. So they see that high-risk response. They can deal with it in the moment. The patient's right there in the office. If there's some crisis intervention that needs to happen, they have the resources and the team, and they're in the setting of the primary care office. There's a level of discomfort for providers to say, we're now sending this out to people's homes, and they're filling it out, and that there's this asynchrony where they're submitting the information and I might not see it until a day later, or if I'm on vacation a week later, what happens to that period in between? And what about the patient? Are they sitting there with suicidal thoughts? And what's the risk and liability there? So there was a lot of concern around that. There's a lot of requests around protocols on how to manage that, of course, and then once also for a protocol, they want those decision support tools to be really built into the EMR to how to respond. So if, what's the appropriate response? Is it a phone call to the patient? Is it schedule the patient for an appointment? And then also building out how do we do a safety assessment if I call the patient over the phone? So there's a lot of requests for more education around suicide assessment, but also tools specifically around what to do in this specific scenario of electronically submitted information that's when the patient's not in front of you. And that's a new area. We don't have a lot of experience or research to know what to do about that because, we've always relied on the paper form where the patient's right in front of you. So this is a new area for us to look into. So this is my summary slide. So going back to where we started around the goals of implementation around the eCare PHQ-9 and where we are now after our implementation. So one of our big goals was patient care. So patient engagement that we've all been talking about. And, with the PHQ-9 being available electronically, this could really help promote self-awareness, self-management. I think one of the other speakers was talking about having just that information, just that increased measurement somehow improves care. And we've seen that as well, just doing some of our pilots, that patients seeing that information and having more touch points to actually measure their symptoms seems to help improve care. Utilizing the ePHQ-9 also can enhance quality of clinical care. It now allows us to do this remote clinical monitoring. You don't have to have a patient come in and fill this out and give you this information. They can be at home and send this information to you electronically, and it allows the provider to access that info, track a patient, provide appropriate clinical treatment interventions. And the key, the areas where I've highlighted or put in italics are areas that we want to enhance or more opportunities for us to think more how we can better in process improvement deliver this care, which is that clinical decision support tool. That was the kind of feedback that we got from providers, is how can we provide that kind of clinical decision support, and what are the best practices around that? What are the right protocols? And that's an area of opportunity that we want to learn from and try to develop. In the area of improved data capture, we've seen that it does, allow for more reliable data capture. As you can imagine, with the paper version, there's a lot of errors that can happen there. In our current flow, you have a paper form, the patient fills it out, they put it on the desk, and the MA currently or clinical staff person would input that information and type it into the Epic. So, that could be missed with the clinical staff person missing a question or marking it wrong. A lot of times the paper form never makes it to the computer. Sometimes it gets lost, it gets thrown in the trash, gets shuffled, and also the information communication piece doesn't always get transferred. So someone in the office paper form might mark suicidal ideation, but it might not, that information not get translated necessarily to the provider. Sometimes the MA will literally walk the paper form over to the provider's desk. Sometimes they'll just leave it on the desk for the provider to see. So there's a lot of areas for misses. So that's one of the reasons why we wanted to move to the electronic version, because we felt like there were less opportunities for misses in that way. So it definitely, I think, improves data capture. It allows for system automation, so ensures appropriate screening. By doing that auto attach, we're now being able to make sure that everyone's getting the screening that's due for the screening. But one of the pieces that we want to look into in our area of improvement here is adjusting the health maintenance reminder. So right now, if you're not familiar, health maintenance reminders, it really tells you when someone's due for their mammogram or their pap smear, and for us, their PHQ-9. And so that specific time frame is set, but we really wanted to align with some of our protocols. So for instance, if you're on the clinical pathway, maybe your reminder is set to a different frequency or cadence than an annual screening, because you're identified as having depression and an elevated PHQ-9, so we should be monitoring you more frequently. So that reminder should be set to a different cadence than general population that is not depressed. So that's one area for improvement. And we could do that based on population. So if you're in one of our population health initiatives, like the clinical pathway, or you're on the PATH program or on panel management, we could have a different health maintenance reminder. And the other area of one of our goals is improved clinical efficiencies. As you know, and we've been all talking about that, it could reduce clinical staff time. So the staff time required to take a paper form and input it into Epic, make sure that the information gets to the provider. All of that requires a human to do that. So by doing this electronically, reduce that clinical staff time needed, and less in-office time spent by patients, as Elizabeth talked about with the annual wellness health risk assessment. This questionnaire isn't very long, but still it takes time to fill out in the waiting room. So less in-office time spent by patients, and then also that that information is already ready for the provider once they show up for their appointment, so they could be reviewed already, ready to talk about that information. And then one other area for improvement is consider other questionnaires that we might, so we obviously focused on PHQ-9 since that's our depression measure, but our GAD-7 is our measure for anxiety symptoms, and technically in our version that we use in the office, we have PHQ-9 and GAD on one piece of paper already. So for those that are getting their electronic PHQ, they still come to the office and get a paper GAD. So we would like to, really think thoughtfully about what other questionnaires are really key for us to be asking and kind of bundle those into kind of a behavioral health bundle of questionnaires, hopefully not too many, but it doesn't make sense to do one questionnaire and then still have them come in and do a paper form of another. So thinking about those improved clinical efficiencies that we can think of. So this is future directions or looking ahead, and forgive the clip art, I got kind of wild with the clip art here, but I think really, as we've all been talking about, is digital innovation, that we're all moving to this. As I think Dr. Chang mentioned, we spend 6 hours a day on our phones or tablets. We're with these devices all the time. And really, our patients are asking, almost demanding, that we have technology available through these platforms so that they can access care. Not a lot of people are using desktop computers anymore, or even laptops in some cases. They're using their phones as their primary tool that they're engaging with, or their tablets. So figuring out how we can use the eCare PHQ-9 to be sent to a mobile phone instead. And that will just increase the likelihood of being able to capture that data. So if you get an eCare message now, you have to go on a desktop, log into your account, then fill out the questionnaire. If you were able to do it via text, I think you're more likely to capture that information. And then also some of the ideas and innovations that other people have talked about today already, having technology be more interactive. So some of the kind of wild, or maybe not so wild ideas that we could think of is, if someone marks suicidal ideation on their phone, could they get some kind of push notification or kind of a text box that gives them crisis resources, or, even direct, alert somebody else at a call center and they get a call back. I mean, there's all different ways that we can think about this linkage happening via technology and utilizing the resources. And that would also reduce clinical time. So, rather than getting a call or having to kind of follow up in the office, if they get the resources and the information that they need right then and there, right to their phone, that would improve patient care and clinical efficiencies as well. And then I like somebody else mentioned digital navigation. Could you push a link and that it connects you with a call center that navigates you to making sure you have an appointment, making sure you have the crisis response, phone calls if you need. So there's all sorts of different innovative ideas that I think we can think about that are new and exciting to think about how we could best help patients. So that's mostly all I have, and I think we're saving questions and answers for later. So thank you.
Hi, thank you so much for giving me the opportunity to talk a little bit about our work at the Madison HIV Clinic at Harborview, where we've been focused on integrating patient-reported outcomes into clinical care. I'm going to talk for just a second about why we do it, although I think to this audience, I'm really somewhat preaching to the choir. Patient-reported outcomes such as substance use, mental health, and in the case of HIV, we're very focused on adherence to antiretroviral therapy, are key drivers of the outcomes of our patient. By collecting this information, we have the opportunity to enhance patient-provider communication, thereby improving clinical care. And because this is clinically very important data for outcomes, it also facilitates clinical research. I consider talking about practical considerations, and here is just a few of the things we had to consider for implementing the PROs into Madison Clinic. However, virtually each and every one of these could be a half-day session, so this is clearly a tip of the iceberg slide that I'm not going to get into, but I do think it's worth sort of noting that this is a complex, complicated issue. That said, what I would like to spend my time doing is describing a little bit about what we have in fact actually done. We use a web-based survey software application that was designed by Bill Lober and his colleagues. Patients complete the surveys on touchscreen tablets at the time of the clinic appointment. We don't have people scoring things by hand. We don't have people sort of doing that kind of data entry and scoring. We have found this to be highly acceptable and feasible to our patients with HIV, and I'll talk a little bit about that data in just a minute. aggressively incorporate skip patterns because there's a lot of really rich, interesting information we'd like to know about our patients, but we are integrating into clinical care, and we know that after a certain amount of time, patients aren't really still focusing on your assessments, so we target an 11-minute maximum assessment for our patients. We offer it in multiple language. English, Spanish, and Amharic are the 3 most common languages in our HIV clinic, so those are the 3 languages we offer it in currently. And the platform that Bill has developed does a number of things that makes our world a much better place. For example, it tracks the time and eligibility to complete the assessment. So if a patient is coming in every day for 2 weeks for wound care to our clinic, I don't really want to either cause the patient burden or the impact on clinic flow of having them complete the assessment every day for 2 weeks, nor do I want a nurse or an MA trying to track and follow that. So having all of that tracking and all of that sort of work done automatically within the platform is a tremendous time saver for us. Patients don't get a mouse, they don't get a keyboard, they get easy to use radio buttons. There's a wealth of data that even among our elderly patients, our patients from other countries, our patients who are less tech savvy, that getting rid of the mouse and the keyboard makes many of these approaches much more feasible and acceptable for our patients, for all patients. We ask a range of information, and we focus really on what's most clinically actionable. So we target things like substance use, depression, anxiety. We also look at symptom burden, physical activity. We focus a lot on risk behaviors. We are an HIV clinic, so HIV transmission risk behaviors, including sexual risk behavior and sharing needles and injection drug use. And recent additions that have been incredibly popular with both our patients and our providers include the addition of intimate partner violence, and the current expansion is focused on adding homelessness and social support as additional domains to our assessment. So it's really, truly a rich wealth of information that we collect approximately every 4 to 6 months. We have done literally dozens of studies with our patients and our providers. This is an iterative process, so I can't really go into all of them, but we've worked with our patients and providers on domain selection, on feasibility, on how they tolerate it, on how much burden it is. But I did want to just discuss a couple of these acceptability and impact studies because I think it's worth spending a couple of minutes on it. So as we implemented the patient-reported outcomes in our clinic, we did usability testing, think aloud testing, qualitative work with our patient groups, both in focus and interview settings. And there were recurring themes that I thought were very supportive and satisfying, if you will. Patients found that the system was easy to use. They were never required to remember their patient login or their patient portal password, or there was no sort of skills that they were required to know, or numbers or passwords. So they found it very, very user-friendly. And they felt that the information that was elicited by the platform was useful for either their clinical care or patients in general, relevant and important. And when we really dig into what the patients feel about this, they found that the overall experience was positive, and there were a couple of reasons, including that it sort of prompted or encouraged their own self-awareness of some of their symptoms and risk behaviors, and it challenged them to be both more honest with themselves and with their providers, particularly about some of their risk behaviors, which I thought was a tremendous theme and finding that we saw over and over again and was very reassuring. We similarly did stakeholder interviews and qualitative work with providers and staff. And what the theme we heard over and over from our staff was about the unrecognized or the under-recognized risk behaviors such as alcohol use. I've known that patient for 10 years. I had no idea he restarted drinking 5 years ago. I remember when he quit and I stopped asking the question, or he didn't volunteer the information. That was a theme we heard over and over and over again. Providers felt it was an icebreaker. It's not that it replaced the discussion with the patient, it's that it allowed them to start the discussion in a meaningful way. And it was because we were very careful about the 11 minutes, it was only minimally disruptive. They didn't feel like we sort of messed with their clinic workflow, which of course would have been the death boon to the whole process. This is an example of some of the quotes from the interviews with providers, and I'm not going to read them all, but I do like that the providers appreciated how often they were aware of problems they didn't know about. I was stunned by how many people had some level of active depression symptoms. He drank a lot more than I realized. It allowed us to engage in real issues, and it was integrated very quickly. These sorts of themes came up over and over again with our provider interviews. This is some quantitative quantitative data we collected on acceptability from our patients in the Madison Clinic. 5 is best, 1 is oh dear, and we had patients rate various aspects of completing the clinical assessment, and they found it was easy to use, it was understandable. It helped them in describing symptoms and behaviors to their providers. It wasn't too long. The one thing is, it wasn't probably the most enjoyable thing they did for the day, but let's face it, I'd like to hope it's not the most enjoyable thing we do in a day. And so as a result of this, within Madison Clinic at Harborview, there have now been over 11,000 of these clinical assessments completed to date by 3,200 of our patients living with HIV that we see in our clinic. Our refusal rates are very low. They're approximately 1%, but I do want to point out that's a refusal rate. So there are several reasons that we just postpone it to the next visit. If you come in and you are completely drunk and intoxicated, I don't really feel like the PRO data is my top priority, and we don't ask you to do it. If you come in and you've already vomited 4 times and you're working on number 5, I'm trying to improve clinical care and not torture patients. So again, we don't ask it. We often postpone. If the patient comes in 20 minutes late for the appointment, we get them in to see the provider. We don't have them spend the 11 minutes with us here. We're always sort of trying to optimize clinical care, and there are times when it's just not appropriate. And in that setting, of these 11,000 assessments that have been done to date, greater than 95% of the time, the results or the feedback are in the provider's hand when the provider sees the patient on that same day. So we are very happy that patients find it acceptable. We're very happy that the providers didn't hate us, particularly as I'm one of them, and that it was integrated into care in a way that wasn't disruptive. But our goal was always about improving clinical care. And so this was another study we did. This is a before-after. So patients were completing the clinical assessment, and this is looking at patients before and after we started giving the feedback to providers. And what we wanted to know is if that had any impact on provider awareness or actions for key clinically relevant domains. This is a bit of a complicated slide, but what you can see for each of these domains, these are patients who report on the clinical assessment that they are moderate to severely depressed. So on the PHQ-9 we were just discussing, they have a score of at least 10, that their adherence to their antiretroviral medications is inadequate by every definition, having missed 3 or more doses in the last 4 days, or that they have hazardous drinking, et cetera. You can see what the domains are. Among these patients who were reporting these symptoms and risk behaviors, this is how likely the provider was to document some awareness of that problem in the clinical documentation from that day and that visit. I will point out several things. One is that after we began giving feedback, which is the gray bars, this went up across the board. Now, there's a couple things I want to point out. The first is depression. The difference between before and after is somewhat artificially small because, as we just discussed, the importance of the suicidal ideation, we always notified the care team of suicidal ideation even before we had implemented PRO feedback as a routine part of clinical care. So that blue depression bar is a little bit artificially elevated. I also want to point out adherence. Our providers were aware of the importance of adherence. We are, after all, HIV, where adherence drives most of our outcomes, both before and after. But I want you to look at the third set of columns. This is inaccurate adherence documentation. So these are patients who are missing multiple doses of their antiretroviral medications, but the provider documented that day missed no doses, perfect adherence, taking all of their medications. And so what you can see is this is the one column we'd like to see go down after the PRO feedback, and it responded appropriately. On the bottom is actions. So this could be any action relevant to that domain. So increasing the dose of an antidepressant, referring to a case manager or a mental health provider, referring to a pharmacy-assisted adherence intervention, et cetera, whatever the intervention might be. And what you can see is that after the PRO feedback for each of these domains, the likelihood that a provider for these at-risk patients for each of these domains had some action, some intervention, was higher after versus before the feedback. Although I will point out that for the sexual risk behavior, that difference was not clinically significant, statistically significant. I would argue it's clinically significant, but not statistically. And so I think this is an example of a study that shows it's not just that we can get the patient and provider buy-in. It's not just that we can implement this in a way that's not disruptive. I think this study is an example of this is actually one of my favorite studies because I think it shows we actually have the ability to change care for our patients by implementing this data. So I want to talk a little bit more about the platform itself because we are a little bit different. We used a standalone platform, and I think that actually provided us with a lot of advantages that made us able to do this. In addition to the fact that the EHRs we used at Harborview changed over this time frame, but beyond that, I think there were a lot of advantages. So we have a different approach than some of the things we've talked about today. We're not hoping for the 4% or the 40% who might have a login to their patient portal. We want everybody. And in fact, the people who are least likely to have a cell phone are most likely those patients who have the most at-risk behaviors, the most depression, et cetera. I actually noted how low your suicidal ideation rate is, and I suspect that has to do with the one, we're HIV, but two, we're everybody, not just the people who are willing to complete the PHQ-9 form. So with that said, we integrated it as a clinic-based assessment first. We offer it in multiple languages, which is easy to do with the platform that Bill developed, and we modify it. This is a very iterative process. So for example, when we integrated the Amharic version, our third most common language, we found that patients who speak Amharic are a little less facile with touchscreens and things. And because we controlled the platform, we were able to do an Amharic recorded introduction that plays as part of the PROs just on the touchscreen itself. And that greatly increased the ability of some of our Amharic patients to be able to complete this without difficulty and to find it acceptable and easy to use. We've added things like, we call it the what's this, but we've added little buttons that if they touch it, it defines a word. So behaviors change. In all of our clinics, things evolve. So for example, when we designed the PRO assessment, vaping and e-cigs was not on our radar. It wasn't a thing. We added some items about cigarettes. But clearly behaviors, and both in the HIV world and in the real world, have evolved. And so we continually modify our assessment to capture what's going on. But that doesn't mean some of our older patients are going to recognize the word vaping. It doesn't mean all of our populations are going to recognize all of the terms we use. So the ability to add this what's this button, they simply touch it and it defines the word that they might not recognize. And it's not that there's a bunch of words that need defined, but because we are continually interacting with our patients about what they like, what they don't like, and what they understand, we're able to modify as needed to make sure everybody comes along, not just specific people who are at sort of higher levels of various skills. And we have the ability to show pictures. This is an item from the Audit C, which is a very common screener for alcohol use. But in addition to what's considered a standard drink size being very different in the US than in Australia, what's considered a standard drink size varies across 10 patients. So I have patients who tell me they only had 2 beers yesterday, but they mean the 40-ounce cans, not the 12-ounce cans. So the ability to incorporate pictures and try and make the results you're getting from your patients a little more comparable, I think is really important, even for instruments that have been used for many, many years and are well validated. Often we can do better. I also think a real strength of the PRO platform is how adaptable it is. I mentioned the e-cigarette use, which wasn't even a blink on the radar when we first developed our instruments, but there have been other changes as well. And I suspect, although my examples tend to focus on evolutions in what's drug of choice or substance use changes in our patterns, I expect all of us see changes over time. And so being able to adapt. So we also provide PROs and work with other clinics, and I'll talk about that more in a minute. But when Johns Hopkins is noticing a lot more fentanyl in their heroin use, it's very easy to quickly add an overdose item and respond to whatever's going on in a clinical care setting at that time among a population. And I think maybe one of the most important things that the platform allows us is this complicated conditional administration, this very complex skip logic, because as I mentioned, we have 11 minutes. That's it. And there is so much clinically relevant, very interesting, very important information we want to collect. The list of things we want to add is always always much longer than 11 minutes. And so being really able to target things both lets us collect better data. So the binge item is modified appropriately for men versus women, right? So the number of drinks that's considered binging in women is different. And being able to have the platform incorporate demographic information, clinical information, et cetera, and modify the instruments or target the instruments appropriately to men or women or transgendered individuals, et cetera, is a real luxury that we value greatly. But also the fact that domains that are changing very slowly get skipped down and are asked less often, except if the patient has already responded that they're at risk at that domain, is a really nice way of maintaining a set time period and not getting longer and longer and impacting clinical flow, but still collecting all of the various domains that we think are valuable, that we, the providers and the patients, think are valuable. This is an example of a feedback form. We ask our providers what they would value, and what they told us is not that they wanted, for example, a comparison with population norms. What they wanted to know was how this patient was changing over time. So we see the last 3 assessments the patient has completed, and what providers wanted wasn't sort of standard errors or complex psychometric sort of summaries of these instruments. They wanted the bullet point, and they wanted it in red if they really needed to look at it, with the most clinically relevant thing at the top, and they don't want to see the whole list of symptoms. They just want to see the ones that are having an impact on the patients at that time, et cetera. And so by being able to sort of ask our providers and modify it to do what they want, we can really target our provider feedback forms in a way that provides a rich wealth of information that they can look at very quickly, so that the feedback and the collection isn't what drives the appointment. It's that they now have the 2 things they notice on here that allows them to spend the appointment time having the discussion with the patient. And, there was several comments earlier today about pilotitis and expanding out and those sorts of issues. So I do want to talk a little bit about what we've done with the PROs. So because we were able to integrate them into the UW-Madison HIV clinic, and because we were acceptable and because we impacted clinical care, we had the opportunity to expand across a network of HIV clinics. So there are 8 HIV clinics, all of whom have different EHRs and different clinic flows and different setups, who have integrated the clinical assessment that we started here at Madison Clinic. And at this point, greater than 80,000 of these clinical assessments have been done to date, with almost all of them providing feedback to the provider to improve care for that patient on that day. This is for over 20,000 patients living with HIV across the U.S. And while my talk is really focused on the impact for a patient, because this is an engagement discussion, and so I focus very much on that the patients had input on the domains, the providers, and how we can change care for the individual patient, I do want to highlight that the clinics we work with across the U.S. value this on a more population level. It allows them to understand changing trends in risk behavior, changing panel outcomes, and it allows them really to assess for unmet clinic needs. Do we have a lot more intimate partner violence at our clinic than I knew of? Do we need an intervention here? Do we need to make a change? Do we really understand where our resources are being spent and where they should be spent? So there's also, and while I'm not really going to go into it in this talk, there's a lot to be said about this at a broader, more population level. I showed this slide not because I'm focused on research, but I think it highlights, this is an example of the patients from the PRO data we collected that were published just in 2018. And I think if you focus on clinically relevant data to improve clinical care, it really provides a great opportunity, not just to help the individual patient, but because this is such relevant data, to address questions that are important for improving care more broadly. So many of these are HIV, very specific papers, but there's also things on here like the Annals of Internal Medicine paper that are really about improving care, not just at an individual clinic level, but much more broadly across the U.S. for these patients. And I sort of took credit for many things here, and that's really not fair. There are way more colleagues than I could ever name in a 10-minute talk that contributed to this work, but I do want to particularly highlight Bill Lober and his informatics team, including Justin, who did all of the work to make this platform what it is. And I think without that, this would not have been feasible. The ability to sort of add things easily, to work in multiple languages, to adapt quickly to new things we're finding out from our patients and our providers, all of that is because of the platform. So I do want to highlight him. And then I want to highlight Rob Fredrickson, because he is who led year after year after year patient acceptability work, patient engagement work, focus groups, interviews, think aloud, qualitative work on this to make sure that our patients really are getting the value we think they are.
I really appreciated both of your presentations. Denise, I think you really showed us how complicated it can be to implement even a single measure across multiple workflows and multiple teams. And Heidi, your work really shows how valuable it is to iteratively evaluate and use that feedback to optimize workflows and the tools that you're using. So we'll open it up to Q&A. We'll give just a couple minutes if there are any questions.
Heidi, how do you balance, as a researcher, and I'm sure there's some academics in the room, that desire to add new questions and the research and clinical, and how has that gone for you?
Yeah, I think that's a great question because it is a bit of a challenge, although I will say, because we focus on clinically relevant as our top priority, much of what's clinically relevant is also what we should be doing research on. So I think that helps a little bit with that sort of dichotomy. If we do our research on the things that are most clinically relevant, our research has a lot more relevance to patients more broadly. And so while I always want to know one more thing, and we didn't talk about it, but we use this as a platform to do a fair amount of research as well, where we have 1,000 people complete the food insecurity item. Just, is this really driving our outcomes? I don't know. Let's look. Let's find out. So we actually use this as a research platform for a number of questions as well. But I think by always having clinical care be our top priority, that also is not a bad thing for our research. It really allows us to prioritize.
So do you follow up, I guess when I hear that, you have the clinical piece and then you do maybe some of these add-ons where you're saying, oh, and would you like to participate in X, or you're eligible to participate in X?
Yeah, that's a great question. And we do it, as I mentioned, we do this across 8 clinics. Every clinic we work with, how they decide what happens there is a little different. And so that is a much longer question than you really wanted. Because now you're sort of getting into IRBs, and those are site-specific.
Great. Other questions? Yes.
Not a question so much, but I listened to Bill talking about the great advantages of nimbleness and of customizability, which are the things that really he's been able to do for the HIV clinic. And we really struggle with a big enterprise implementation of EPIC to try and figure out, in a world where we have to be standardized in order to be successful in our maintenance and ongoing work, and in our priorities and our resource constraints. And I would love if, as this group keeps working, we find some ways to balance and bridge those things, because it's been a real challenge in the PRO space for all of us who've been trying for these past couple of years to make that work better. And so it's great to see these other solutions, but they clearly have advantages and disadvantages in terms of some of that maintainability across the system. And Bill's one person, and there's only so many places he can go. And we all know that our demand for PROs is huge across the system, and we've been pretty limited in our ability to meet that.
Great. Thank you, Jane. I don't know if either of you want to comment on that. I think it really speaks to the importance of us understanding what matters to us as a system and to our patients, and really using those goals to drive us in the right direction as we find that balance between standardization and customization and a lot of the opportunities around us. Any other questions? Okay. Sarah, if you don't mind turning the projector back on. Okay, so we have made it through the morning. Do you guys have any closing comments before we...
No, go ahead. No, it's great just to learn from all the different experiences, and I have specific questions that I want to ask you guys, but it's great. I've really enjoyed it.
I enjoyed your talk as well, and one of the things I found really well, there were many things I found really interesting about your talk, obviously, but the couple of things that I thought were really intriguing is one, how low your rate of suicidal ideation is compared to ours, and then the fact that your providers are so concerned about that. I mean, I think often educated providers, information is power rather than, oh dear, we don't know. You know, it's putting our head in the sand is sort of not necessarily the best way to improve our outcomes. So I thought that was really intriguing. And I will say that for our providers, one of the things they valued most about the PRO implementation is that we sort of took the how do you deal with that out of their hands. So some of our providers are warm and fuzzy, and some of them are not necessarily who I'd want to discuss suicidal ideation with. And so at Madison Clinic, when someone reports that, the pager that goes off, well, the provider always gets notified. By the time the provider sees the patient, one of the case managers has already assessed the patient and made sure they had a 1-800 number and et cetera, et cetera. And for the most part, it's very rare that those patients need to go to the ER and have a huge intervention. But someone who is appropriately able to have those discussions, someone who is good at those discussions has had it with the patient before the provider even sees them, and the provider can then, you know, depending on their skill set, add on, et cetera. But I think that may be the thing our providers actually value the most is the suicidal ideation issue.
Yeah. And I think the real issue that we've seen is what do you do when you do it out of office? Because you can do that level, and we could do even that level because we have social workers in our behavioral health integrated sites. But when you take it and have patients fill it out of office, then you don't have a case manager right there to deliver that 1-800 number, right? So that's the big concern, I think, is around what if they report those symptoms and they're not right in front of me, that I don't have the tools and resources and people around me to help address that. And I think that is the challenge. And it's interesting because I think, as far as we know, we're one of the only systems that are really trying to do the full PHQ-9 on an electronic platform like this. You know, we've talked to a lot of different other systems to try to research. You'd be amazed what people do. I mean, they just chop off the last question. They ask a PHQ-8 instead of a 9 because they want to put their head, their head in the sand and not ask those questions, and they feel like it's better not to ask. Whereas, we as behavioral health folks and, the chair of our department said that, that's putting your head in the sand. It's actually worse care because you're not, you could actually do something for that patient if you knew that they were having suicidal ideation by not asking them. That's worse care for them. So we don't feel that way. We really want to gather that information, but we want to provide providers with a reassurance that if we get that information, that we have a response that's appropriate. And the other interesting, and we could talk forever, I think, but some of the data that we've gathered, that Courtney, the research assistant, that's been helpful in interviewing patients and getting feedback. For those that did have suicidal ideation responses, we did some patient interviews to ask them what their responses were, and what is the appropriate response? Does everyone get a phone call, or does everyone get just a text box warning, and that's sufficient? So we were trying to figure out what's the appropriate response. Some patients, in our interestingly, in the auto attaches where we saw most of these high-risk responses, not the manual one, which is interesting because the manual one usually are people that are being seen regularly by a therapist or counselor. We thought that, we'd see more of those high responses. It's really the people that are getting screened at a population level that are responding to this, that are, just like you pointed out, I didn't know that they had depression or suicidal ideation before now, so that's almost a surprise event. But the idea is, that, how do we capture that information and make sure that it's relevant to providers?
Yeah, thank you.
I have one very quick comment on suicidal ideation. Sort of the most interesting thing that we've ever done in that arena was about 10 years ago with Hall Health. We implemented an online anonymous screening tool that allowed that encouraged a student to convert to an identified encounter. And sorry, I knew this was going to happen. I was hoping to get through it quickly. Anyway, suicidal ideation. We did this interesting project about 10 years ago with Hall Health here, aimed at doing screening for students. We did anonymized screening. And then if the student screened positive, they were given the option of converting by revealing their identity or providing their identity and converting to an appointment with Hall Health Behavioral Health Services. Mm-hmm. And I won't tell you what we did, but we had to consider what happens if you have an anonymized suicidal ideation intent, and then what happens if you have an after-hours converted intent. And I think that thinking those things through starts to make it a little bit more accessible to think about what institutional out of clinic use might be.
And I
But
think
great project
yeah.
anyway.
Thank you, Bill. So I'm going to cut us off because we are over time. And I hope that by this point in the day, everyone in the room can agree that a lollipop is not going to suffice for patient engagement. And if anyone thinks differently, come find me at break and I will try and catch us all up to speed. But over the course of this morning, we've given you a lot of information and hopefully a lot of perspective. And so we're about to head into lunch and then our working breakout sessions. And this is the point that you all can put your thoughts into action and dig into the opportunities for patient engagement in targeted clinical areas. So as you have these discussions, we really encourage you to think big. Danielle mentioned blue sky earlier this morning. We want you to think beyond what you already know about our tools and experiences here at UW Medicine, and consider the perspectives that have been shared both from our internal UW Medicine community and from the external community that have come here today. And start to articulate a vision for patient engagement, how it should look, what tools we need, and what currently stands in our way.